The following podcast is part of a certified educational activity titled Examining the State of the Science on New Therapies in Bladder Cancer, Perspectives on the Latest Developments Across the Disease Continuum, featuring Professor Thomas Poles from Bart's Cancer Institute in London, United Kingdom, Dr. Petros Grivas from the Fred Hutchinson Cancer Research Center in Seattle, Washington, and Professor Andrea Necchi from IRCCS San Rafael Hospital and Scientific Institute in Milan, Italy. Access the entire activity and complete the post-test at peerview.com/ECU860. Downloadable slides and practice aids are also available.
Hello, and welcome to Examining the State of the Science on New Therapies in Bladder Cancer, Perspectives on the Latest Developments Across the Disease Continuum. I'm Tom Poles from Bart's Cancer Institute. I'm joined by my great friends and colleagues, Petros Grivas, from the Fred Hutch in Seattle, and Andrea Necchi from San Rafael in beautiful Italy. I'm now going to take a little look, and I'm going to start off, if I may, with the agenda. So we're going to talk about new advances for the early stage disease. We're then going to go into the advanced stage setting, and then we're going to talk about non-immune therapy options. I'm going to start talking about non-muscle invasive bladder cancer, and then a tiny bit about muscle invasive bladder cancer. And then clearly we're going to move on to locally advanced, unresectable, and then second-line disease, as you would expect. So we're starting from the beginning with early stage diseases and some of the new advances in this setting. Keynote 57 and pembrolizumab's approval is really important. It's an approval based off approximately 100 patient study looking at pembrolizumab in BCG refractory carcinoma in situ. And it's resulted in an FDA approval in this setting. This is an overview of the results on the left-hand side. And you can see here, primary endpoint was the CR rate. You can see that while the CR rate was high and 39% of patients responded, or 33%, the durable CR rate was quite modest, actually. And you can see this from the Kaplan-Meier curve in terms of the duration of this response, which I think is reflective of the disease and the fact that carcinoma in situ, particularly BCG refractory carcinoma in situ, is challenging to treat. This is actually a very attractive option for patients. Petros, I don't know how much of this you're using currently in the US, but my impression is patients will do almost anything to delay their cystectomy. Is this a treatment that you're using a lot in Seattle?
Thank you, Tom. I agree with you that patients like to have options, and definitely having an option that is not surgical is appealing to them. I make it very clear to the patients, Tom, that the standard of care in this setting is radical cystectomy with pelvic lymph node dissection, and I prefer that approach for sure in BCG unresponsive, high-risk non-muscle invasive disease. But for patients who are very frail and not able to undergo that surgery, or they refuse it despite strong counseling, we have used pembrolizumab based on the FDA label in this setting in very few select patients.
What do you think about durability of response, Andrea? Do you think that the durability is impressive, or do you think there's more work to do here still?
Thank you, Tom, and welcome everyone. Yes, I think that it's promising, of course. But the most important limitation of the study is the short-term follow-up, and I'm quite convinced that urologists will be more happy to administer pembrolizumab when we will achieve a longer-term follow-up data on this trial, also based on the data that have been generated with a totally different approach, like data with nadofaragene or other intravesical therapy. So here the struggle seems to be systemic versus local, but the play will be a long-term with long-term follow-up for these patients.
Thank you, Andrea. We've also got some results on atezolizumab in this setting. It actually had quite similar CR rates at 6 months, and if you look at the CR rates at 3 months, that was 42%. So I think when you look at this from a distance, the efficacy data for pembrolizumab and atezolizumab actually looks quite similar. but only one of the two drugs is FDA approved, and we wait longer follow-up for both studies. As Andrea said, nadofaragene is an adenoviral therapy associating with delivery of local IL-2 intrathecally rather than intravenously. And this is attractive for urologists. There are also antibody drug conjugates which are being investigated in this space, or which are targeting EpCAM, which I think are exciting and also have FDA fast track designation. And we've talked a little bit about some of the anti-PD-PD-L1s, which actually are being broadly investigated also in randomized trials. So I'm going to park the non-muscle invasive place and move on to a case, a 45-year-old lady who presents with hematuria and good renal function, cytoscopic and imaging techniques are consistent with a mass in the bladder wall, and she's diagnosed with pathologically C2, N0, M0, muscle invasive urothelial cancer. And one of the questions which I guess I'd like to ask the group really is what are this patient's current treatment options? And Andrea, perhaps I could start with you, how you'd approach this cisplatin eligible individual with T2, N0, M0 disease.
Yeah, thank you, Tom. So the standard of care basically in the European and US recommendation is still to administer neoadjuvant chemotherapy and radical cystectomy for such a patient. And I would say that based on the fact that we are dealing here with a female young patient, of course, there is the alternative option of chemoradiation to offer and to as a bladder sparing strategy. And I'm quite sure that mainly in countries where chemoradiation strategy is frequently adopted, like in the UK, this type of patient actually is more than happy to receive a bladder sparing strategy. But this is a typical case with a limited tumor T stage, T2 stage, for whom we may provide two really alternative options that are chemoradiation and the neoadjuvant chemotherapy. So the most important message here is for the community is that there is a huge opportunity here if a radical cystectomy is planned for providing a systemic therapy rather than jumping directly into radical cystectomy to the operating room for cystectomy.
Petros, what's your take on this? This patient would get neoadjuvant chemotherapy and cystectomy. Do you have to give neoadjuvant chemotherapy? Could you give adjuvant chemotherapy instead in T2 disease, or do you have to give any chemotherapy at all?
Tom, I agree with Andrea that the standard of care and level 1 evidence in cisplatin fit patients is neoadjuvant cisplatin-based chemotherapy, and I strongly recommend this to colleagues in clinical practice. I offer cisplatin-based chemotherapy to all my patients with muscle-invasive disease, T2, T3, or T4A clinical stage, and even in patients, with N1 disease, who are surgical candidates, I offer them this approach. I think that the two regimens we use in clinical practice is either gemcitabine cisplatin. I do it every 3 weeks on a 3-week cycle for 4 cycles, or dose-dense or accelerated MVAC every 2 weeks with growth factor support. And I think, the evidence of overall survival benefit in the older trials using MVAC and CMV in Europe strongly support this approach in patients who never receive neoadjuvant cisplatin-based chemotherapy and come to my practice, Tom, with PT3 or PT4 or node-positive disease, and they're fit for cisplatin, and they never got it neoadjuvantly. I tend to offer cisplatin-based adjuvant chemotherapy in those fit patients, PT3 or higher stage, who never got it before.
I tend not to offer adjuvant chemotherapy for what it's worth. I do in upper tract disease based on the POUT study, but I tend not to in other disease settings. So I think there is some debate about adjuvant chemotherapy, but certainly neoadjuvant chemotherapy, I think we can all agree, is the standard treatment. There has been some progress with immune checkpoint inhibitors in this space, and this is an overview of the atezolizumab, pembrolizumab, and nivolumab programs. Disease-free survival is the primary endpoint of all of these trials, Many people feel that one needs to achieve overall survival, and certainly neoadjuvant cisplatin-based chemotherapy achieved overall survival. Adjuvant chemotherapy achieved disease-free survival successfully with hazard ratios of 0.5 in the EORTC studies, but never achieved significant overall survival, which is why it was not routinely taken up with level 1A evidence. So there is a question about whether disease-free survival is the right endpoint for these trials, which is something that we can debate in a second. IMvigor010 was a study which included over 800 patients. It included high-risk individuals who had had cystectomy, and they were randomized to atezolizumab or observation. The trial was unsuccessful for disease-free survival. The hazard ratio was 0.89 in unselected patients. The curves go apart and come back together, which is slightly unusual for immune checkpoint inhibitors. Usually they start at the beginning and then together and then go apart in the future. And again, there was no significant overall survival benefit either. And so it was somewhat surprising that we have seen in the last couple of days the Checkmate 274 trial being read out at GU ASCO this year. Very similar design, actually, high-risk patients. Perhaps the placebo made a difference. The other study, atezolizumab, did not have placebo. And here you can see the trial met its primary endpoint, disease-free survival, of 0.70, with the confidence intervals going to 0.89. The PD-1 positive population showed further enrichment to 0.53, which is clearly impressive. And this data, I think, is important, but I don't know if it changes practice. Perhaps, Petros, what's your take on these data?
So, Tom, I agree with you. This is probably one of the most important data sets presented at ASCO GU this year, and we're all waiting for the important results of this trial. The disease-free survival benefit is important, and I agree with you that this is a positive trial. However, in my mind, I always, think about it as a concept. Is disease-free survival the right endpoint, as you mentioned, in an adjuvant clinical trial where patients have no discernible visible disease and they're probably less, interested in getting potential toxicity? In my humble opinion, overall survival is ideally the right primary endpoint. Now, can you argue about the surrogacy value of disease-free survival? Is DFS a surrogate for OS? There have been some older studies, retrospective studies, and some data from Dr. Sombavde about 10 years ago in patients with cystectomy that showed that a 2-year disease-free survival may be a surrogate for overall survival.
That was chemotherapy, Petros, not
That's exactly right. That's exactly right, Tom. You're exactly right in my mind. This data is in chemotherapy setting, but not on immunotherapy setting. So I'm not feeling comfortably extrapolating this in immunotherapy trials. And ideally, I would like to see what happens with overall survival in terms of being convinced on practice-changing results. What do you guys think about that?
Andrea, what's your take on this?
Yeah, the potential of using adjuvant immunotherapy, if we look at the shape of the curves, typical shape of the curves with the use of immunotherapy in the context of metastatic disease or earlier setting disease, is that we may have the potential to find out some association of longer-term disease-free survival and overall survival. So I would not be negative in principle. Of course, the follow-up time of Checkmate 274 is still a bit short to envision this future and to have a final word on this association, of course. And the other point that would play in favor of using disease-free survival rather than overall survival, I would say, is that the landscape of possibilities for treatment of patients with advanced disease or relapsing after primary treatment is increasing. Of new possibilities, ADC, FGF receptor inhibitors, like as we will see in the next slides. So I think that the end point of overall survival is becoming not so clean as it was until a few weeks and a few months ago. So let's see a long-term follow-up, but then I would be moderately positive in terms of using the DFS as a potential registration endpoint.
Can I add a quick comment, Tom, on that? You mentioned before about, chemotherapy. You do not offer chemotherapy adjuvantly because there's no level 1 evidence of overall survival data. It's interesting to think about, in the same context, would DFS be the right endpoint for immunotherapy if we did not, feel very convinced with chemotherapy? I'm just curious to hear what you guys think.
I mean, I think it's a complicated issue. I think in Europe, people will be looking for overall survival. I think in the adjuvant setting, where inevitably a large group of patients are not going to relapse, you will be overtreating a group of patients by treating unselected individuals. And in that environment, I think if one only delays the disease-free survival, but do not improve overall survival, I'm not sure adjuvant therapy has a huge role to play. So, but with a hazard ratio of 0.53 in the biomarker positive population, I'm fairly confident that one's going to hit overall survival. The 0.70 is grayer to me. So I think that this data will be looked at very carefully by the clinical community. And I can see some people saying, no, I want OS definitely. And I did a Twitter poll of 300 people who answered, and about 70% of people wanted OS, irrespective of disease-free survival. So it's only 30% of people who are convinced by this DFS endpoint as it currently stands. But then a DFS of 0.53, that's pretty impressive. And I suspect the agencies might look at that biomarker positive population, particularly in Europe, and provisionally go down that route. I obviously have no idea about that, and I'm not involved in the process. I'm going to keep going, I think, because I've got lots of slides. Listen, this was a trial that was successful. We've done lots of other studies which have also been successful recently in urothelial cancer. And the BCAN clinical trial dashboard can be used to find trials that fits individual patients' needs. And I really do encourage people to visit that site. I'm going to talk about frontline disease as well, of course. And if I can kick off the current status of novel therapeutics in metastatic bladder cancer, in the cisplatin eligible space, we've actually still very much based around GemCis and GemCarbo. And excuse me, in the cisplatin eligible space, we're based around GemCis, obviously, in dose-dense MVAC, and we're sequencing avelumab maintenance first-line therapy in those patients who have not progressed on therapy. In cisplatin ineligible biomarker positives, there is this discussion about gemcitabine and carboplatin, followed by maintenance avelumab with level 1A evidence. But we've also seen some data at ASCO GU this year for atezolizumab and pembrolizumab in this space. Neither of these trials, randomized trials from 361 and 130, were significant to support their use to beating gemcitabine and carboplatin, but the hazard ratios of 0.82 and 0.51 are quite impressive, although the numbers are small, 80 patients and 50 patients. I think, as I currently see this, the current standard of care for this group of patients is GemCarbo, followed by maintenance avelumab in those patients who have not progressed. Atezolizumab and pembrolizumab don't get great control of disease in the majority of patients. And the biomarker data, it seems to be pretty uncertain as it currently stands. So I think for those patients, or those doctors who are treating patients, unless you're treating a huge number of patients and you have a really good feel for atezolizumab and pembrolizumab in this space, I think gemcitabine carboplatin followed by maintenance avelumab is more attractive. And then, of course, we've got prior platinum-based chemotherapy for those people who relapse within a year. And there are a series of different treatments which are attractive in this group. And we're indeed going to talk more about those treatments today. I've previously described the GEO-ASCO updates from 2 randomized trials testing atezolizumab and pembrolizumab in biomarker positive cisplatin ineligible patients. This is the single arm data, which is now 4 or 5 years old for atezolizumab and pembrolizumab in this space, which is what the labels, the approvals were based around. And you'll be aware that these approvals were changed to focus on the biomarker positive population because of, I think at the time, concern that in the unselected patients, atezolizumab and pembrolizumab were not active enough. We now know this biomarker story hasn't panned out particularly well. And I think that this area of frontline cisplatin ineligible disease has a degree of uncertainty. What I can say is both pembrolizumab and atezolizumab probably have similar activity, but I do think the biomarkers are very different. And as it currently stands in the randomized trials, the 142 biomarker seems to be slightly better. This moves us on nicely to IMvigor 130. I've already described the cisplatin eligible monotherapy data for here, but what I'm going to do next is I'm going to talk about the chemotherapy combination data. So this is GemCis or GemCarbo versus GemCis or GemCarbo plus atezolizumab. These data were presented back in the day when we were doing face-to-face meetings in ASCO 2019, I think. And this is the Lancet publication. Essentially what this shows is modest progression-free survival benefit. The curves only go apart actually once the chemotherapy finishes. And so the maintenance period may be driving a lot of that benefit, and no significant overall survival benefit yet, although this trial is not yet mature. And so this is a study which is not yet cooked, but the benefits look modest, and some of the benefits is likely to be coming from the maintenance period. There doesn't seem to be a huge amount of synergy associated with chemotherapy and immune therapy, and indeed the pembrolizumab data, which I might gloss over very quickly, for pembrolizumab plus chemotherapy, which was a negative trial, showed similar effects. This is the outcomes for the cisplatin ineligible patients, and I've already described this data in the cisplatin ineligible. And you can see here the hazard ratios of 0.53 for the current label looks attractive. And I think these data will be looked at in some detail. I don't know, Andrea or Petros, how you feel and whether these data change your opinion of this setting.
Well, I think that the issue still remains regarding the management of patients who present with more aggressive disease. So I would remain a bit concerned about administering first-line checkpoint inhibitors regardless of the biomarker expression in patients presenting with a rapid aggressive disease, hepatic metastasis. So I would definitely favor, in particular for this type of patients, the administration of upfront standard chemotherapy. We may discuss, I think, in more in less aggressive disease patients, like patients with lymph node only disease, if there may be a case of switching the therapeutic options. But I think that for the majority, I totally agree with you. The primary approach will still consist in standard chemotherapy.
Petros, I'm going to ask you a question on this case here. So this is an individual diagnosed 2 years ago with muscle-invasive bladder cancer, and then quite quickly undergoes a cystectomy, followed by adjuvant GemCis, which, as I said, I probably wouldn't have given, but there we go. A CT scan shows bone relapse quite soon after that. And then they receive more cisplatin-based chemotherapy, which is incredible. It achieves a CR after 6 cycles, which obviously is terrific news. And the question for you is what do you do with this patient who's responded to therapy, and what's the next treatment for this individual?
Sure, Tom, thank you for the question. So the interesting thing is there is the timing of the recurrence between the end of adjuvant chemotherapy and the time of the recurrence. It sounds like it was about 1.5 years. So that probably what prompted the treating physician to reintroduce cisplatin-based chemotherapy. But now after 6 cycles, the patient achieved complete response. And we have now level 1 evidence, Tom, from the trial that we conducted, the Javelin Bladder 100 trial, that showed a significant overall survival benefit with switch maintenance avelumab in patients with either response or stable disease to platinum-based chemotherapy in the induction phase. So in these particular patients, unless there is any active autoimmune disease on steroids, I offer these patients switch maintenance avelumab, and there is an FDA approval in the US, there is a European approval in Europe and many other countries. And even if you look at the different subsets of patients, I think that, with variable degrees and magnitude of benefit, I think the benefit with avelumab seems consistent to me across the board, across different subsets. So I will offer this patient switch maintenance avelumab.
Yeah, I have a question to both of you.
Yes.
What about a case of a case presenting with a disease confined to the lymph nodes in the pelvis, N2 disease, let's say, and receiving first-line chemotherapy and achieving a complete response after first-line chemotherapy? What about this case? Would you consider surgery for this case, radical cystectomy and pelvic lymph node dissection, or would you consider maintenance immunotherapy for such a case?
So, Andrea, we tend to not, in advanced disease, we don't do too much surgery in the UK in our practice, and we probably wouldn't be offering surgery to that individual. I think that surgery in advanced urothelial cancers, it's quite challenging, and the surgeons I work with, they're nervous about doing that, and so we tend to steer away from that. And indeed, we have quite complex discussions, particularly in upper tract TCC, when there's present N2 disease, about whether the role of surgery after neoadjuvant chemotherapy, because I know you can get us even after neoadjuvant therapy, if chemotherapy is associated with these spectacular responses. My experience is after surgery, the cancer tends to come back. And so I tend to steer away from, because the surgery is not small surgery, it's a big operation. So we tend to steer away from it.
Yeah.
And we in Seattle here, we have a bladder cancer interdisciplinary clinic that we do every Tuesday morning, and we have cases like this, Andrea and Tom, and the majority of the patients go on maintenance therapy, as Tom mentioned. However, having said that, we have some few select patients, younger, very fit patients, very well motivated, very good surgical candidates with long life expectancy, that after a tumor board discussion and the interdisciplinary evaluation of images, we have offered in few select patients, consolidation surgery, especially, for patients with N2 disease. If it becomes N3, it's even less enthusiastic, and definitely we do not offer it for M1 disease. So it's a very select, case by case discussion based on the patient characteristics.
I think we need to talk about that more in public. We don't talk about it enough. We all have our dirty secret patients who we operate on, and I don't, because we do, and I select, as you do. We think about it very carefully. My experience is they tend to relapse, and it doesn't go well. In kidney cancer, I treat a little bit of kidney cancer too. Things can be a bit different. If you get a CR and you remove the kidney, sometimes you can have a durable, but I don't see that often in urothelial. In fact, I'm going to show some slides in a second. I'm going to go on to this right now. So this is the Javelin 100 study. This is the maintenance study. Those individuals who have advanced urothelial cancer, 4 to 6 cycles of standard frontline chemotherapy, no evidence of progression of disease, randomized to avelumab or best supportive care within 10 weeks of completion of treatment. Overall survival is the primary endpoint of the trial. Hazard ratio of 0.69. Curves go apart and stay apart. Avelumab is associated with 21 months median OS, which is obviously impressive. We also showed a significant benefit in the biomarker positive cohort. This was a co-primary endpoint of the trial. I think this is relevant because we did show some enrichment, but it's also important to look at the subsets in this study. And what I can tell you is that in broad terms, all of the subsets favored intervention with avelumab versus best supportive care alone. And these subgroups, which I think are particularly relevant, which I'm asked a lot about, was type of chemotherapy, gem-cis or gem-carbo, both benefited from maintenance of avelumab. I think presence or absence of visceral metastasis, and you can see here, both benefiting. PD-L1 status, positive or negative, both benefiting towards maintenance avelumab. And then the last one is response to response to therapy. So a previous response to chemotherapy, and Petros presented this data and there was the stable disease patients, the partial response, but also the complete response patients benefited from maintenance of avelumab. One of the things that struck me about the complete response data is in the best supportive care arm, median progression-free survival in complete response bladder cancer patients is only 4 months. We often think of complete response as cure. We certainly do in kidney cancer. I don't necessarily believe that, but certainly outcomes in that group are excellent. And we're seeing in bladder cancer actually that even this complete response group, so we go back to the patient who the patient case we saw who had a complete response. I think it's important that actually that duration of response, median duration, is only 4 months. And therefore, in my opinion, intervention with maintenance of avelumab is attractive. Petros, Andrea, you've both been involved in this. And Petros, what's your feeling on the totality of the efficacy data for maintenance of avelumab? And are there any patients who you feel particularly should get therapy or subgroups who should not?
I think, Tom, overall, the totality of the data strongly show a significant benefit with avelumab maintenance. And as you pointed out, the hazard ratio 0.69 in all comers is important, is impressive. There is an enrichment, as you mentioned, PD-L1 positive patients, that was a co-primary endpoint. But based on the slide you're showing, I think the benefit to me appears to be across the board and across different subsets of patients. Yes, there are different degrees and magnitudes of benefits. Some groups may benefit more than others, but I think overall, the benefit is consistent, so I do not pick or select. I offer this strategy to any patient with response or stable disease in clinical practice after induction chemotherapy, as long as they have no contraindication to immunotherapy. And I think that there's very interesting biomarker data that you alluded to that Dr. Sridhar presented nicely at ESMO 2020, which is great, hypothesis generating data. However, I don't think the biomarkers are ready for prime time to impact clinical decision making. And in my practice, I offer avelumab switch maintenance to every patient with response or stable disease, CR, PR, or SD.
Andrea, I've always been very impressed with your biomarker data out of the Pure1 program, and I know that you've done a huge amount of work on this issue. Could you just give me some impression of where you think we're going with biomarkers in urothelial cancer and what you've discovered so far in your work?
Yeah, what I've seen in the early disease setting is that probably if we look at the gene expression signature more than TNB or PD-L1 expression, we may identify a subset of patients who may be the outlier responders of immunotherapy alone, at least. If we look, for example, at the basal subtype tumor or patients with the Claudin low subtype, which is a restricted subtype within the basal subtype with the highest immune gene signature, these patients are actually predicted to get the most benefit, the highest benefit from the use of single agent immunotherapy. And coming back to this slide, I totally agree with both of you regarding the fact that the maintenance immunotherapy still is to be provided to all comers. But the slides also tells us that there is an extraordinary opportunity for next clinical trials, which should be aimed at intensifying therapy in poor disease, in poor outcome patients that are represented clearly here by patients presenting with a stable disease in visceral metastasis. And then there is an extraordinary opportunity for the next clinical trials to try to improve further the outcomes by intensifying, for example, the switch maintenance phase.
Andrea, that's really interesting. I think there's an opportunity here as well. And I know that there are some maintenance trials ongoing. Some of them talk about shortening the period of chemotherapy that looks attractive. Others talk about building up and giving combination maintenance therapy, which is attractive too. And I know we're going to talk more about enfortumab vedotin later on today, which I think is a different approach, which also bears merit. So I think this is a very exciting area. It's important for me to talk very briefly about the adverse event profile associated with avelumab in the Javelin 100 program. It's what one would expect with approximately 50% grade 3 or 4 treatment emergent adverse events 12% of patients discontinuing because of toxicity, and a similar proportion of patients requiring high doses of steroids. At GU ASCO, there is some work from Johan in the Javelin 100 program, and this looks at duration of cycles of first-line chemotherapy. You'll be aware that that standard treatment is 4 to 6 cycles of treatment. The median number of cycles given in the trial was 6, but actually there are a significant proportion of patients, probably those who are running into toxicity actually, on chemotherapy, who are only getting 4 cycles. And when one looks at this subgroup of patients, it looks like their outcome with avelumab is about the same. That doesn't mean it's safe to crop chemotherapy, but avelumab works equally well if you can only get 4 cycles in compared to 6. Very important differential there. So we're not advocating giving cropping chemotherapy. What we're advocating is if you do have to be in a situation where you're only giving 4 cycles or 5 cycles, maintenance avelumab is still indicated. This is an audience question. Do patients who progress on avelumab maintenance after chemotherapy have the same third-line options as patients who progress on other checkpoints? Does the choice of upfront chemotherapy make a difference when considering PD-L1 maintenance in complete responders? So those are the 2 questions which we're asking here. And I don't know which one of the 2 of you would like to take the first question and which one would like to take the second. Andrea, I think it's your chance to go first. So would you like to answer the first question?
Okay. So it's an interesting question. I still think that we are collecting data on this matter. We don't have numbers that are suggesting that patients relapsing after maintenance immunotherapy should have different third-line option as patients who were relapsed after first-line standard chemotherapy and second-line standard immunotherapy. So actually, as far as the type of therapy that should be offered to this patient, and as far as the potential efficacy and the responses that we may obtain in these patients, we don't have substantial data that are suggesting a difference between the 2 populations. So basically, if a patient relapses or progresses during or after maintenance immunotherapy period, there is still almost the same opportunity to rescue this type of patients, just like we are in the clean third-line option after two disease progression that occurred previously. So we don't have any major difference according to the data and to the literature that we have accumulated so far.
I think that's right. I would standardly give more chemotherapy as it currently stands. I'd like to give infliximab vedotin. It's not yet available in Europe. I'm sure you're giving that, Petros. Petros, do you want to, I know you're going to talk more about that in a minute. Do you want to talk about the second question, if possible?
Absolutely. So I think it's important to point out that we presented data, Tom, together with other colleagues from the Javelin Bladder 100 trial at ESMO 2020, and we actually tried to break down the patient population of Javelin into those who got induction phase of GEM-CIS and those who got GEM-CARBO. And we actually showed that the benefit with avelumab switch maintenance in terms of PFS and overall survival appears to be significant in both of those subsets. So both in patients got GEM-CIS or GEM-CARBO. So the short answer is that both populations appear to benefit in a similar fashion. Having said that, if I'm given the option to select which induction chemotherapy I'm giving, I strongly favor cisplatin because I think the outcomes with cisplatin-based chemotherapy are better compared to carboplatin-based chemotherapy. You can argue there are many confounding factors, the patient protoplasm.
I'm going to do that in a second.
Right. And you can argue that, but I think in patients who are fit for cisplatin, I think that's what I'm doing in clinical practice. Having said that, someone who cannot get cisplatin, I'm giving them carbo-gem. I think the benefit with avelumab appears to be significant in both of those populations.
What I'm saying at the moment is that GEM-CARBO is probably 10% less active, in my opinion. Now, where do I come up with that data from? Well, actually, I know that Maria DeSantis' EORTC study showed that GEM-CARBO patients did really poorly with very short survival. I'm not sure that's realistic of what we're currently doing in urothelial cancer. I agree there are some patients who are not fit enough for chemotherapy. But if you look at the IMvigor 130 trial and you look at the GEM-carbo versus the GEM-cis patients, the median progression-free survival of those two groups was very similar, although, of course, the PS2 patients or the less well patients inevitably would get GEM-carbo, and the overall survival was also very similar. And so it's my opinion, and the other trials largely show similar things. And so, it's my current opinion to say the following. Number one is, yes, if they're fit enough for GEM-cis, they'll certainly give it. But don't think that GEM-carbo is not active. GEM-carbo is active. And my fear is that we're not treating enough patients with poor performance status with chemotherapy because everyone thinks GEM-carbo is not useful. But actually the IMvigor data, which is an over 1,000 patient trial, showed actually quite similar outcomes. So it's a controversial area. In broad terms, I agree with what you've said. But I think that the nihilistic approach of saying, well, they're not fit enough for GEM-cis, they're not PD-1 biomarker positive, so we shouldn't be giving them anything. That's not my current approach. My current approach is saying, let's get in some chemotherapy, get in control of the disease, and then switch to maintenance of avelumab with stability. And indeed, as Johan's previous slide shows, patients who have 4 cycles of chemotherapy who got maintenance of avelumab seem to do quite well with it. And so I think that getting in control early disease is important. Come back to Andrea's point previously, which I totally agree with. In advanced disease, highly aggressive disease, chemotherapy is quite effective initially for metastatic urothelial cancer. And my temptation is to give those. I'm going to hand over to Andrea, I think. Andrea, you've got a really exciting talk to give, which I'm looking forward to. Do you want to fire away with that?
Thank you, Tom. So my task would be to guide you in what is currently ongoing in the post-immunotherapy setting. So let's focus a little bit on selected patient population, where I will provide you with some insights into the FGF receptor inhibitor developments in bladder cancer. So let's start from the case of Thomas, who is a patient progressing on a frontline GEM-cis chemotherapy, and then receiving second-line PD-L1 inhibitor. And then we are in February of last year, a disease progression with visceral metastasis. And then we actually provide a next generation sequencing on the archival tumor samples related to the bladder tumors, to the radical cystectomy that was performed in 2018. And we also performed at the time, so in February 2020, a ctDNA assessment with a liquid biopsy. And both of these assessments, so on tumor tissue and in blood sample, revealed an FGF receptor 3 mutation, a driver mutation of the gene. So which would be the next step for such a kind of patient with a confirmed FGF receptor alteration, and who has already received and who has relapsed after chemo and immunotherapy. So the rationale for developing FGF receptor inhibitors in urothelial cancer is based on the fact that we are dealing with the clearly recognized driver mutation of a gene, which is determining the disease. The problem surrounding the alteration, when looking at the clinical application and when looking at the clinical trials and clinical practice, is based on the fact that we are dealing with a small fraction of patients that is approximating 10%, 15%, or 20% at best. The major difference in terms of frequency are related to the clinical stage of the disease and to the tumor tissue in which this mutation is assessed, because in non-muscle invasive disease, the frequency of rearrangement or mutation is a bit higher than that observed in tumor biopsies from metastatic sites or radical cystectomy. And the other point is that we know that FGF receptor 3 alteration are enriched in upper tract tumors. So we have a different distribution according to the topography and to the source of the primary tumor tissue based on the primary tumor type, which is clearly higher in the ureter and the renal pelvis tumors. And the third point, which is important to highlight, is the fact that in the case of Thomas, in the case of the patient that I presented, we have an homogeneous result between the archival tumor tissue assessment and the ctDNA assessment. But in fact, if we look at the timing from the archival tumor sample analysis and the ctDNA assessment at the time of treatment initiation, there may be some big difference or significant difference in terms of possibilities to recognize or to lose the mutation of the gene. So it's important. It's important to deliver the message that potentially, when looking at patient at the later line therapy, so in second line, third line therapy, it would be better to look at the ctDNA assessment or tumor biopsy made immediately before starting any other further treatment options, rather than looking at all the tumor tissue from the archival samples. And let's look at the BSc 2001 study, the erdafitinib study. This study actually tested different doses of erdafitinib, starting from 6 milligrams once daily to the intermediate dose, and then leading to the registration dose of 8 milligrams daily, with the possibility to up titration at day 14 based on the phosphate levels. And this study actually was a phase 2 single-arm study testing different cohort. But based on the results that we will see a little later, erdafitinib treatment has been preliminarily approved by the FDA as a treatment option for patients with FGF receptor 3 or 2 mutation or rearrangement, and having already received at least one line of chemotherapy or plus or minus one line of immunotherapy. The data on the long-term response actually confirmed that the 40% response rate achieved with erdafitinib is substantially maintained over time with long follow-up time. This is the original publication from the New England Journal of Medicine by Loriot and colleagues on the preliminary outcomes of the study. These are the original PFS and overall survival data, with a median PFS of 5.5 months and the median OS of 13.8 months, which is noteworthy actually in third line or fourth line option for metastatic patients. And these are data that have been updated at ASCO this year with longer term follow-up, with 2 years median follow-up, substantially confirming that the outcomes in terms of PFS and median OS are the same of the preliminary data. Subgroup analysis, of course, revealed that we may have a confirmed activity of erdafitinib regardless of the subgroup of patients, regardless of the type of FGF receptor alteration, the type of the source of the primary tumor, the site of the primary tumor, upper tract or lower tract, the line of prior therapies, and in particular the use of prior immunotherapy and failure of prior immunotherapy. There seemed not to be any difference, substantial difference in patients who have failed in their story prior immunotherapy compared to the immunotherapy naive patients. So I would like to ask Tom and Petros, what is your feeling regarding a patient who have achieved a very good response to immunotherapy and then a relapse? Do you see that there may be still some difference in the patient who are predicted to be very good responders to immunotherapy compared to patients who may be good responders to FGF receptor inhibitors?
I mean, I think that it's a really tough question. I think there is some evidence, and some of this comes from the TCGA analysis, which suggests that FGF alterations, tumors with FGF alterations, tend to have a lower immune infiltrate. and lower PD-L1 expression, and there's some data to support that as well. I think that there is some data which counters it, single-arm data in the neoadjuvant setting, which shows some FGF mutations are associated with PD-L1 positivity. There's a lot of uncertainty about the biomarker, and I talked about the PD-L1 biomarker previously, and I said that there are more unknowns than knowns around that in this disease. One could say the same about FGF, in that we're looking at FGF2 and FGF3, and each program uses a slightly different biomarker. Some use circulating biomarkers, others use tissue-based biomarkers. I've even seen some data on RNA expression for FGF, looking at selecting patients based on that. So I think the first thing to say is, are we confident about the biomarker? And the answer is, I think modestly, and certainly the response rate of 40% does look attractive, and progression-free survival of 5.5 months, a median overall survival of 13 months in a pre-treated environment in a select population looks pretty good. The question from my perspective is it better than enfortumab vedotin, which has a randomized trial in what would be a second-line space, post-chemotherapy and maintenance of avelumab? And I probably would say at the moment, I would rather be giving enfortumab vedotin. But I'm happy to have that discussion. And I think it's one of the more difficult questions in urothelial cancer that we're going to need to answer. Where do we sequence FGF? Now, it's essentially the only drug which is supported by a single arm trial. The PFS data doesn't look out of this world. Do we need to be giving these patients this drug, or should we be giving with level 1A randomized data instead?
Yes,
Petros, for your thoughts.
Petros, which would be your ideal sequence for a patient relapsing after first-line chemotherapy and not receiving any maintenance immunotherapy, but for whom we know that there is an FGF receptor 3 alteration?
Sure. So let's say a patient gets Gemcis or Gemcarbo frontline, which are the most commonly used regimens, and has a primary progression, never got maintenance therapy. I think that, at least in the US, the options right now would include checkpoint inhibitor, and the checkpoint inhibitor in platinum refractory disease with level 1 evidence is pembrolizumab. And that's a separate discussion about that choice of checkpoint inhibitor, but that's one option, or erdafitinib. And erdafitinib has accelerated approval based on the single-arm phase 2 study that, Andrea, you just presented. So there is a difference in the level of evidence. Pembro has level 1, the erdafitinib is coming from a phase 2 trial. Having said that, there is an ongoing trial called THOR, T-H-O-R, which is comparing head-to-head pembrolizumab with erdafitinib in the biomarker selected patients, FGFR2 or 3 mutation or fusion. So that trial will probably answer the question of the optimal sequence of, you give checkpoint inhibitor or erdafitinib in those patients. What am I doing in the clinic right now? I look at the patient and I try to answer the following questions. Do I need a response right away? Do I have like a vital organ being in danger, in risk, and I need a response immediately? I may select the agent with high response rates. Or, however, again, these agents have not been compared to each other. So may consider erdafitinib versus checkpoint inhibitor in this scenario. If a patient is otherwise, has no need for immediate response, maybe a lymph node only disease, the patient wants to go with level 1 evidence, I may choose checkpoint inhibitor. Also, the toxicity profile may be different. So a patient with active autoimmune disease, I may use erdafitinib. If not, I think checkpoint inhibitor is an option. The other quick comment I have is, going back to the debate that Tom mentioned before, you have data suggesting, retrospective data, that the response to checkpoint inhibitor may not be as high in those with FGF receptor 3 mutation or fusions. These data are contradicted by some data by Dr. Galsky and others that show that you may have similar response rates. And the answer to that is because you may have less T cell infiltration by T cells in those mutated FGFR3 mutated tumors, but this may be counteracted, or let's say negated by less immunosuppression in the stroma of the tumor. So I think the jury is still out there. We don't know for sure. There is uncertainty, to quote Tom, about the optimal sequence of those agents in patients with a biomarker. In terms of testing, I do it FGF receptor and other genomic sequencing. I do it at the time of diagnosis of metastatic disease to inform my subsequent options after platinum-based chemotherapy.
Petros, question for you. So I kind of agree with you. In primary progression on cisplatin-based chemotherapy, immune therapy is unlikely to work in my experience. The challenge, I guess, is that if you want to use FGF inhibitors, you're going to have to get the test sent off, and that's going to take a couple of weeks to turn around. What is the optimal timing of FGF analysis, and what tests do you use?
Great question, Tom. I do the testing right away upon diagnosis of metastatic disease. So even before I start GEM-CIS or GEM-CARBO, I get the testing done. And there are two options. There's the FDA-approved label, this PCR test, RT-PCR test. But the reality is, Tom, I think in the US and probably in Europe, people do a broader genomic sequencing testing, and there are multiple vendors out there, not to mention specific names, but I think people go with a commercially available broader genomic panel sequencing, and the results can be back in about 2 weeks. So the patients may get GEM-CIS or GEM-CARBO, and you get the test back and you can use it at a later time point. So you don't need to rush at the time of progression. So I do it early on. Now, the last point is we have a trial in the adjuvant space with, I think Andrea will show the slide, with infigratinib versus placebo adjuvantly. And this trial is screening patients with a FGFR mutation or fusion. So in some patients might have it earlier, but in patients who do not go on screening for that trial, I do the testing, broader genomic sequencing at the time of diagnosis of metastatic disease.
Thank you guys for your insightful comments. So let's move forward. And we have mentioned, and Petros have mentioned rightly, that the problem of treatment-related adverse event, which are not so negligible, and that we should, then the community of physicians treating and using FGF receptor inhibitors should be well aware of the fact that we may have some specific side effects related to the use of erdafitinib as well as other FGF receptor inhibitors. The overall incidence is represented here in this slide, but it should be noted also that the incidence of grade 3-4 of this type of side effects is much lower, is lower than 10%, is approximating 2% for hyperphosphatemia. Stomatitis in BLC study is a bit higher, is a grade 2 or 3 or 4, as represented in almost 13% of cases, but all the rest of the toxicity proportional less than 5%, occurred in less than 5% of the patients, so that we are still dealing with rare cases, but we should be well aware of the fact that the occurrence of this type of alteration of side effects actually needs specific treatments. The data from the erdafitinib phase 2 study are being challenged in the phase 3 Thor study, and this study is actually targeting the second and third line setting with two different type of comparison: erdafitinib versus investigator choice chemotherapy represented by vinflunine or taxane in patients who had already received in their treatment course an immunotherapy, or erdafitinib versus pembrolizumab in patients who are immunotherapy naive. The primary endpoint is overall survival, so the trial is accruing very well worldwide. So let's see if we will have the possibility to say a final word on the role of erdafitinib versus the competitors in this clinical setting. The other interesting issue is that erdafitinib response rate is quite higher than that reported with other apparently similar pan-FGF receptor inhibitors like infigratinib, pemigatinib, regorafenib, and vofatamab, with the only exception of vofatamab, which was an antibody anti-FGF receptor and not a TKI pan-FGF receptor inhibitor. So a quick comment from all of you regarding this slide. What is in two words the main reason of this such a difference? Is it a difference that has to do with the testing, with the biomarker, so with the population, consequently, or with the inherent activity, different activity of the drugs? Petros.
In my opinion, it's probably a little bit of both. I think it's both the drug is also the biomarker. Obviously, as you saw here, the only agent that has an FDA approval is erdafitinib based on the response and durable responses in the Bill C-2001 trial. The interesting thing with regorafenib is the different biomarker, right? So they use this mRNA in situ hybridization testing, and the concern has been that if you use the mRNA expression with regorafenib, you may have a broader pool of patients, about half of the patients, versus the 20% with bladder cancer with the erdafitinib testing. And if you have a broader population with mRNA testing, you may dilute your signal. And that's, I think, a valid concern that may have impacted the results of the 4:1 trial with regorafenib versus chemotherapy, the phase 2/3 trial that we saw last year. So I think it's probably a mixture of both, the drug itself and the biomarker testing.
Okay. Tom, which is your feeling?
It's hard to disagree with Petros on this, and one looks at this and says, well, the drugs probably have more similarities than differences. But I think, unlike the immune checkpoint inhibitors, I think that there probably are subtle differences between the drugs. But clearly, we've also shown from immune checkpoint inhibitors that patient selection is absolutely crucial in outcome.
Thank you, Tom. Let's move forward. As I mentioned, we may have special toxicities related to the FGF receptor inhibitors, and one of these special toxicities is related to the ocular toxicity, in particular the central serous retinopathy, which is a quite rare event, but still needs a specific management and multidisciplinary management with the ophthalmologist. And it's the same for hyperphosphatemia. So it's important for this type of treatments when you are starting them with your patient to actually deal with the multidisciplinary approach with the people with colleagues from other disciplines. In the case of hyperphosphatemia, for example, a consultation made by a nephrologist or suggestions or nutrition, for example, that may be useful in order to limit the rise in phosphate during treatment is actually the winning strategy at long term in order to have the compliance of treatment at its best. There are initial experience in managing the combination therapy, including FGF receptor inhibitors. These experiences are very preliminary. One of the first experience that was altered in its development has to do with the vofatanab combination with pembrolizumab. An interesting thing that was presented with the combination therapy with vofatanab is that if we proceed the combination therapy with the 1 or 2 courses of FGF receptor inhibitor alone, we may shift the microenvironment from non-inflamed to inflamed, and then potentially leading to a higher response with the combination therapy. But this program, the clinical program of FIRST-22, was halted by the company. And the second combination of regorafenib and the atezolizumab is in phase 1 and 2 development. And here in this case also patients are being selected based on the mRNA expression of the gene. So we are observing interesting response rate of 60% with the preliminary data. Some issue on the safety of the combination, but let's see with larger data if the combination therapy may have a role, and which role in the treatment course of these patients based on the developments of other compounds that are surrounding this type of development. As Petros has mentioned, that there are trials that are testing the use of single agent FGF receptor inhibitors in earlier disease setting. We have seen the extraordinary results from nivolumab therapy in the adjuvant space from the Checkmate 274. There may be a role still for selected patient harboring FGF receptor 3 alteration in radical cystectomy or nephrorectomy to be considered for this type of trial instead of receiving adjuvant immunotherapy. In particular, 2 studies are currently ongoing in Europe and worldwide. The Proof 302 is comparing infigratinib and versus placebo as an adjuvant period in high-risk patients, like patients with a PT2 or PT3 or PT4 or PN plus disease after neoadjuvant chemotherapy, or in patients who are not eligible to receive adjuvant chemotherapy and who are chemotherapy free, who never received any chemotherapy before intervention. These are patients that are clearly at high risk of relapse. And the same for Pegasus. The inclusion criteria in terms of the definition of high risk disease are pretty much the same. In this case, we are selecting patients with a PT3/4, so we are excluding the PT2 disease. And in this trial, this is a single agent and single arm trial with pemigatinib adjuvant phase for 1 year. One very quick question that I have to Tom is related to the PT2 disease. So do you think that including these patients may be worth in this type of trials? So are patients with the PT2 disease and zero disease actually at high risk of relapse, or a sufficiently high risk of relapse to receive 1 year period of treatment?
It's a really good question, and I don't know the answer to it. I'm involved in a trial which recently has adjusted its entry criteria to exclude these patients. The event rate is lower. I think that we also need to look at both the atezolizumab study and the pembrolizumab trial. I know it's not an FGF inhibitor, but we need to look and see what the hazard ratio in the T2 patients is in the forest plot analysis. And there is a suggestion that higher risk patients may benefit more from immune checkpoint inhibitors. Obviously, they're going to have more events, so more benefit, more events. It strikes me that actually the T2 patients may not be worth bringing along because you end up diluting your signal, not getting enough events and having a negative trial. So there are ways of around that. So you can include the patients, but not include them in your primary endpoint. So you include these patients and then you do a subsequent analysis to see if they benefited, and that's a nice approach. But I think the question you've asked is entirely valid, and we've recently changed the trial to exclude this group of patients.
And to add quickly to that comment, Andrea, I think there's a distinction in my mind between upper tract disease and bladder. For upper tract disease, I would include PT2 for 2 reasons.
I agree. I agree with that.
I agree, Tom. And the reason is it's high risk of recurrence in upper tract with PT2, and the other is because the POW trial, Dr. Biddle and Dr. Hussein presented, included PT2. So for context, I think it's reasonable to include PT2 untreated in upper tract. For bladder, I would include a Y PT2, only neoadjuvant chemotherapy treated that has PT2. I would include that part, but if it's untreated, no neoadjuvant chemo, I would not include PT2 for bladder cancer.
So there is still a bit work to do in homogenizing the criteria for the adjuvant trials. Thank you. And then finally, in a slide which is showing the data that have been presented at ESMO last year from the BSC 2001 study over erdafitinib, looking at the ctDNA analysis in patient treated with erdafitinib, and showing that there is a landscape of alterations surrounding the FGF receptor 3 alteration. And in this case, for example, EGFR alteration coupled with the CCND1 alteration and BRAF alteration may help combined to identify the patient with the worst prognosis if these mutations are present. So maybe that there may be further elements to select patients if we don't know yet if this type of alteration actually have a prognostic significance or a predictive significance. But the other point is that we may have opportunities for further targeted therapy in this disease to combine with the FGF receptor inhibitors. So targeted therapy, which has been historically considered as dead in bladder cancer, may be revitalized by translational outcomes that will emerge from these pivotal trials like BRC 2001. So with that said, I finish here my presentation and I read the word to my colleague and friend, Dr. Petros Grivas, who will open up the doors to the advent of ADCs in bladder cancer. So Petros, the floor is yours.
Thank you so much, Andrea, and thank both to you and Tom for excellent presentations and for a fantastic discussion today. I think it's great to think about what the future brings, but also where we stand right now with new agents in advanced urothelial cancer. And I'm going to spend the last 15 minutes describing the landscape, especially with antibody-drug conjugates, and just take a quick glimpse into the future, what is coming up next. And I would like to get both your opinions here, especially with the antibody-drug conjugates in the field. Let me discuss a quick case. He's a 75-year-old gentleman who had metastatic bladder cancer with lymph node disease and lung metastasis. The patient received gemcitabine cisplatin, as Tom mentioned before. Gemcis or Gercarbo are the two commonly used regimens in the frontline setting. The patient finished the treatment and then went on to get a checkpoint inhibitor. It's important to note that the patient had 3 cycles of Gemcis, had stable disease at that time. The patient was tolerating treatment well at this interim time point, but then continued, had 3 more cycles, and had progressive disease, but also significant toxicity in terms of side effects, neuropathy that can happen, especially grade 2 neuropathy, something to keep an eye on with platinum-based chemotherapy. The patient had normal labs except for mild anemia, no autoimmune conditions, and in the next generation sequencing, there was no actionable alterations in FGFR2 or FGFR3. So this patient now has, as I mentioned, progression on the recent CT after chemotherapy, went on to get checkpoint inhibitor in the second-line setting. And we discussed, in the level 1 evidence in platinum refractory disease with pembrolizumab. But whatever checkpoint inhibitor is given, the patient achieves partial response after 3 cycles and has no significant toxicity, so continues on therapy. And this patient eventually has this progression. So at subsequent visit, there's a clinical and radiologic progression. But I want to also point out that when we give immunotherapy, we may have significant toxicity, and this is across the board with all different agents, immunotherapy included. So I want to point out that during the treatment, the patient was doing extremely well, had a partial response, really, really beautiful partial response on checkpoint inhibitor, which is commonly seen, but developed grade 2 immune-related colitis during treatment that actually resulted in holding off the checkpoint inhibitor, and the patient was given oral prednisone at the dose of 1 milligram per kilogram daily dose, and also, as I mentioned, immunotherapy was held. And he went under a prolonged taper. I think it's an important message here for our colleagues in the community. When you treat immunotherapy-related toxicity, I think it's important to do a prolonged taper and not very abruptly, because there is of recurrence of the immunotherapy-related adverse event. And I want to point out there are multiple tools that can help us manage these patients. There are guidelines for immunotherapy-related adverse event management, from ASCO, ESMO, NCCN, SITC, Society of Immunotherapy in Cancer, and other organizations. So I think it's important to utilize these tools and manage the patients, and also educate the patients and the provider team about the potential occurrence of toxicity across different therapies and specifically immunotherapy-related adverse events. So these patients, after having partial response, as I mentioned, and managing the toxicity, he went back on immunotherapy later on when it was considered safe. And then subsequently, after quite some time of doing great on immunotherapy, had subsequent progression. So the question is, what do you do at that time? And if I can pick your brain very quickly, Tom, you can go first. This patient, platinum Gemcis, progression, checkpoint inhibitor progression, no actionable FGF receptor alterations. What would you do?
I mean, I think that for me, I'm very impressed with the EV, the enfortumab vedotin data. I think there's randomized trials with a hazard ratio of 0.7. I think it's an active drug. I think response rates are 40% in unselected patients. I think it's a new, really important step in the right direction to improving patients' outcome in urothelial cancer.
Thank you, Tom. Andrea?
Thank you, Petros. I think that this is the case of representing the most difficult situation that we are living today in countries where ADC and the vast majority of the European countries where ADC are not available. So this type of patient is actually deserving an ADC therapy. So there is an additional point of availability of a treatment worldwide. So these patients, and in most countries, like in Italy or many other European countries, there is a huge difficulty in accessing ADC outside of clinical trials. So from the patient side, I think it's currently one of the most important problems that we are facing today.
I totally agree. I think access to therapy, as you mentioned, and equitable healthcare delivery is a significant problem worldwide. And I agree to your point, Andrea, we have to do better overall as a healthcare society to make sure that patients have access to therapies. So you talked about antibody drug conjugates, and I agree with both of you. I think the data definitely support that approach here. We talk about enfortumab vedotin, and this is an antibody drug conjugate against Nectin-4, which is expressed in the membrane of urothelial cancer cells. And there is significant high expression of this molecule across different tumor cases in urothelial cancer. And that's why we do not select, for Nectin-4 expression, we give the drug in all comers. And this has accelerated FDA approval based on the EV-201 trial, cohort 1, that was published about a year and a half ago. And also now, as Tom implied, there is phase 3 trial data that was just presented at ASCO GU 2021 with significant overall survival benefit, hazard ratio 0.70, and PFS benefit, hazard ratio 0.61 with enfortumab vedotin versus salvage chemotherapy in this third-line setting. So definitely, this is, I think, what we would do outside the context of clinical trials. I agree with you. The other antibody drug conjugate with very exciting and promising data is a sacituzumab govitecan, the IMMU-132. This has a different target. The TROP2 is the target of this one, has a different linker and also a different payload. Enfortumab vedotin that we just talked about, the payload, the chemotherapy toxin, is MMAE, which inhibits microtubules. In contrast, the sacituzumab govitecan has a different payload, the SN38, which is a metabolite of irinotecan, a topoisomerase 1 inhibitor. So different drugs, different structure, different chemistry. They both happen to be antibody drug conjugate, but like with chemotherapy, they have different mechanisms of action. I just mentioned the data from EV-201. This trial has 2 cohorts, phase 2 trial, single agent enfortumab vedotin. Cohort 1 was in patients with prior platinum-based chemotherapy and checkpoint inhibitor. So you can argue this is a kind of a third-line space for most patients. And cohort 2 is patients who got checkpoint inhibitor in the front line. They did not get chemotherapy for advanced disease, for metastatic disease, and they got enfortumab in the kind of second line. Everybody got enfortumab vedotin, single agent at the dose you see in that slide. Starting dose is 1.25 milligrams per kilogram, and those reductions are allowed on the study. This is the data that I mentioned before, cohort 1. As you see, 84% of the patients had some reduction in the tumor size, and overall response rate was 44%. Very impressive data, especially in a disease where the historical context, right, with single agent vinflunine in Europe or taxane in US, the response rate is between 10 and 15%. So definitely, impressive response rate with a 12% complete response rate here. Again, this data led to the accelerated approval of enfortumab vedotin in this pretreated setting after platinum-based chemotherapy and prior checkpoint inhibitor. And we actually saw some interesting results from cohort 2 in ASCO GU 2021. Again, this is applies to patients with prior checkpoint inhibitor, but no chemotherapy for metastatic disease. And impressively, enfortumab vedotin showed an overall response rate of 52%. You can argue the sample size may be small, but definitely a very interesting signal that I would like to get a very quick comment from both of you guys If you can just summarize in a few seconds, what's your impression about this response rate after checkpoint inhibitor, and whether this population exists, at this point? Tom, you can go first.
No, we don't know enough about this population. We know that chemotherapy has activity here as well, but that's all retrospective data. We don't know what the response rate for gem-carbo would be like, but this data looks, in my opinion, at least as good as that. So I think very encouraging. How much single-agent immune checkpoint inhibitors are we going to be using in the future? Probably not that much. So I think it's more proof of the importance of the drug, but this probably isn't where it lands in the end.
Thank you, Tom. Andrea, a very quick comment.
Yeah, I can only echo that, Tom, and your words. I think that the long-term data actually put the EV as a absolutely first option for in the metastatic landscape in the post chemo in post immunotherapy setting. There is not much more to say about that.
Thank you, both of you. And this brings us to the EV301 trial. It's a great segue. The EV301 trial was a confirmatory phase 3 study comparing enfortumab vedotin at the dose I told you compared to single agent vinflunine or taxane, depending on the location, Europe or US respectively. And this was to validate the data from cohort 1 of the EV201 trial that I just showed you, the cohort 1 of the phase 2 study. And it's interesting to see that the median overall survival was significantly prolonged. This data was very nicely presented by Professor Pauls at ASCO GU 2021, and this is really, really exciting. It's a positive phase 3 trial in advanced urothelial cancer that we do not see every day. So congratulations to Tom and the overall team. The hazard ratio, as Tom implied, was 0.70, favoring enfortumab vedotin. And as I mentioned before, there is also a PFS benefit, 0.61, favoring enfortumab vedotin. The response is 41%. I would say, very close to what we saw in the phase 2 trial. So the activity is maintained in the phase 3, and toxicity, of course, is another whole discussion. But I think the data definitely, in my humble opinion, supports, a consideration by the regulatory agencies for full regulatory approval for both US and Europe. And I'm aware to see when this happens down the road. In the interest of time, I will move on quickly to the different antibody drug conjugate, the sacituzumab govitecan. You have seen the data from the Trophy U01 trial. This has 3 different cohorts. Cohort 1 is patients with prior platinum-based chemotherapy and checkpoint inhibitor, like the cohort 1 of the EV201 trial. And I'll show you data from that. And also cohort 2, which is similar to the EV21 trial cohort 2, patients after checkpoint inhibitor, but no chemotherapy for advanced disease. Cohort 3 is ongoing and is combining pembrolizumab with this antibody drug conjugate together. And the data from cohort 3 have not been presented yet. The activity is notable. The overall response rate was 29% in the cohort 2. These are patients with prior checkpoint inhibitor treated with sacituzumab govitecan. We just saw the data from enfortumab vedotin in that setting, and the median duration of response not reached, median PFS approaching 6 months. It was an early read, and we need more data from the cohort 2 from that study. Cohort 1 showed an overall response rate 27%. These are patients that were heavily pretreated. Median number of prior therapies was 3, and there was a range between, I think, 2 and 8 prior lines of therapy. So definitely a heavily pretreated population. Overall response rate, 27%. I would argue about double of what we know with taxane, single agent, or vinflunine. So definitely a promising number here. Median duration of response, 6 months. And I think if you look at the next slide, about 3/4 of the patients with sacituzumab govitecan in cohort 1 had reduction in the tumor size. Definitely, I would say, impressive data. And then the swimmers plot, some patients may have durable response. As I mentioned, the signal in terms of PFS and OS has to be interpreted with caution in a single arm phase 2 study because of potential selection and confounding biases. However, it's a promising signal. You can argue median PFS 5.4 and median OS 10.5 months, which, if anything, supports the conduction of a phase 3 trial, which is a TROPIC-04 trial. This trial design is similar to the EV301. This sacituzumab govitecan single agent, dose 10 milligram per kilogram, days 1 and 8 on a 21-day cycle, versus chemotherapy of choice, taxane single agent in US, Viflin in Europe with a primary endpoint of overall survival and a plethora of secondary and exploratory endpoints. This trial is ongoing. Again, Tropics 4 is important to keep clinical trials in mind across disease spectrum. And I think that's an example of the phase 3 trials right now in the heavily treated patients in the field. So we always want to keep a balanced approach with any treatment we give. We talked about immunotherapy-related toxicity before, and also with antibody drug conjugates, we can see potential side effects. Some examples: peripheral neuropathy, skin rash, and hyperglycemia that we see with enfortumab vedotin, and also neutropenia, bone marrow suppression, and diarrhea we see with sacituzumab govitecan. I think in both situations we can try to manage the side effects. I think there are those holds, those delays, especially for neuropathy with enfortumab vedotin and neutropenia and diarrhea with sacituzumab. And I think it's important to recognize these potential side effects early on, so we can, optimally prepare the patient so they report it and they do not underreport, which is concern we have. Sometimes patients do not report their side effects. And an extra word about the hyperglycemia with enfortumab: check the labs, make sure the glucose is okay, because 1 out of 10 patients may have a hyperglycemia, and half of those patients may get a severe hyperglycemia with enfortumab. So keep that in mind, and I think educate the patients. Very quick comment about the future. I think there is some interesting data set that was presented before with antibody drug conjugate against HER2, especially the RC48 at ASCO 2019, a year and a half ago. We have not seen data yet from the DS8201 alpha, which is another antibody drug conjugate against HER2 that is being tested together with nivolumab. I think this is a glimpse again for the future. I think there's some interest in my mind still in PARP inhibitors. Professor Pauls presented data from the BISCAY trial. I presented data from the Atlas trial. We did not see significant signal, to be honest with you. So I think the role of PARP inhibitors remains questionable, but maybe patient selection and maybe earlier on utilization before platinum resistance may be something to consider down the road. Antigenesis agents plus immunotherapy, I think the concept is very compelling. There are some clinical trials like sitravatinib plus nivolumab presented by Dr. Sowell in previous meetings, showed very interesting data with possible efficacy. And there are also data with cabozantinib, atezolizumab by Dr. Pal and Dr. Agragal. So I think this concept is alive in terms of inhibiting angiogenesis and checkpoint inhibition. And there's a phase 3 trial called LEAP 011 with pembrolizumab plus lenvatinib versus pembrolizumab placebo in the frontline setting. There are other immunomodulators, and I know we had discussed with Tom and Andrea before about some interesting molecules like TGF-beta inhibitors and others, and always the idea of the epigenetic modifiers that can be used in this disease, and there are trials evaluating this concept. So I think the future is bright. We have to do a better job, as you guys mentioned before, in terms of biomarkers. We have to validate biomarkers prospectively, and there is some uncertainty around biomarkers, but I'm hopeful that the future will give us more options for the patients, and we always have to think about clinical trials as a way to enrich our data sets and develop new therapies. With that note, I will give it back the microphone to Tom to close up. Thank you so much.
Thank you, Petros. So immune therapy advances in early bladder cancer have occurred. The drugs have moved quite rapidly into earlier spaces. We need to see randomized trials in that setting. We've got new frontline standard of care with maintenance of avelumab as a standard of care with level 1A evidence, which I think is really important. We've talked about non-immune therapy options, particularly erdafitinib as an FGF inhibitor, and also we've seen enfortumab vedotin as an antibody drug conjugate, both of which are licensed in the US. But the enfortumab vedotin, as Andrea said, looks really promising in a randomized phase, well, looks positive in a randomized phase 3 study, and really is going to change global practice. We need to get access to that drug as quickly as we can. Shared decision-making, we talked about, and Andrea asked that interesting question about surgery. Shared decision-making is really important, and we need to be working in teams, and I think that's a key message. Clinical trials, well, we think they're important. I think they're important for patients, and patients who have taken part in the trials of the drugs I've said, or the trials for the drugs which have changed practice, I think have had benefit. I'd like to thank Petros and of course Andrea for joining us. I'd like to thank the audience. Petros, Andrea, perhaps you'd like to say goodbye too.
Thank you, Tom. I would like to thank you and Petros and PeerView for inviting me to join in this fantastic discussion. Thank you.
And on my behalf, thank you so much, you, Tom and Andrea, for a wonderful discussion. Thank to PeerView and all the sponsors of this program. And thanks a lot to the audience for joining us tonight. Looking forward for more events like this.
Thank you very much, everybody. See you soon.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ECU860. This activity is supported by educational grants from Gilead Sciences, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Pfizer and EMD Serono.